Good morning. I'm Dr. Babak, Larian for our Center for Advanced Parotid and Facial Nerve Surgery. And today we're doing a live question and answer session as this relates to parotid tumors, parotid diseases, salivary gland diseases, and all your questions are welcome. Let me start with the questions that have come in advance already. So first question is by Doris Melgard. Hi again, Dr. Larian. Hello. Is it normal to have a 7 by 3 by 7 millimeter lymph node within the parotid gland? Yes, it actually is. The parotid gland, let me show you. So, when you look at the cross section of the head, this is the parotid gland, which has the facial nerve going right through it here on both sides. And when the parotid gland is developing, it traps in a few lymph nodes within it, right? So here you can see one lymph node there, two lymph nodes here. Let's look at this one. This is magnified. This area magnified here. And so it's not uncommon to have a few lymph nodes inside the parotid gland. Lymph nodes are essentially like army barracks, right, that are filtering through the fluid in the body and surveying them. And once they see something that's not supposed to be there, a virus, bacteria, signs of a tumor, a cancer, so on, they fill up with white blood cells and get bigger and bigger and bigger and bigger, which is why when you catch a cold, your glands in your neck, which are the lymph nodes, swell up. And a lymph nodes that's oval shaped, right? Oval rather than a circle. And has on ultrasound a little bit of a line where the blood vessel goes in called the hilum. Is pretty normal. So 7 by 3 by 7 is an oval shaped lymph node. That seems pretty normal. How about, next question is, how about 2 1.5 centimeter lesions in the submandibular area right below where the 7 millimeter lymph node is? So, okay. So let's go to a different image. So here, the green box, the green area is the parotid gland, and there's a lymph node in there. The blue section here is the submandibular gland, which is also a salivary gland, which is deep to the jaw muscle. Jawbone, I'm sorry. So the submandibular gland is deep to this jawbone, okay? And there's 2 lesions in here that are less than 1.5 centimeters. So it matters if the lesions are inside the submandibular gland, because generally speaking there are no lymph nodes inside the gland, but there's large lymph nodes right behind it, because this lymph node is in charge of what happens in the mouth. So if you have something as simple as gum inflammation, this lymph node would be enlarged. Okay, so if the lymph node is in the submandibular gland, then probably need to be biopsied. If it's outside and a little bit enlarged, that's pretty typical. The parotid lymph node has been evident for a couple of years, but smaller, all right? Cancerous lymph nodes generally don't get smaller. They continue to get bigger. They either slowly grow, so they may feel like they're not getting bigger, or grow fairly rapidly and are obvious, but they don't get smaller. So if it's getting smaller, then we're in good shape. The two submandibular lesions are only seen incidentally on a recent brachial plexus MRI. Looking back on past imaging, only a smaller parotid lymph node was seen. Biopsies are being discussed, but I'm not sure this is the way to go with a history of elevated metanephrines and dopamines. Not sure what to do. Elevated metanephrine is pointing towards something called pheochromocytoma, which is a tumor that produces this particular hormone, all right, and causes blood pressure issues and all sorts of symptoms. That wouldn't preclude doing a biopsy, okay? If in fact the lesions, just like we show here, are inside the submandibular gland, then doing a needle biopsy is helpful, right? It also has to do with the level of stress that you're experiencing, because the metanephrines will make you very stressed and your blood pressure really high. And if you feel like you can't handle doing the biopsy in this situation, then you may need to get that situation under more control, because if you're stressed out and doing the biopsy and these hormones are in your body running high, and then you're scared and you produce your own set of hormones on top of it, you can really go into a crisis, okay? But otherwise, I think it should be okay to do the biopsy, all right? So you just need to work in partnership with your doctor to plan it out. Good luck, Doris. Tough situation. But again, if the lesions are not inside the gland, they're outside of the submandibular gland, they may just be reactive normal lymph nodes, all right? Good luck, my dear. Please update us next time we talk. Stacy Lou, I had a 3.6 centimeter tumor removed and the gland last week. I know I have a fistula. I've had it checked, but it's huge and scary. I haven't eaten for days as it swells bigger. Should I be worried about it, or will it heal on its own? Had it drained yesterday, but filled straight back up. Okay. So I'm assuming you had parotid surgery, Stacy. So let's go to that. Okay. So if you had a 3.6 centimeter mass, which is fairly sizable, that means you had something like this. Okay? So this is roughly 3.6 centimeters. All right. So if you remove this, and we're gonna, find the nerve and then remove that area where the mass was with a little bit of extra around it, then what you have is this cut edge of the parotid gland. All right, you have the cut edges here and all this raw surface in between the branches, which every time you eat produces saliva, right? And that saliva can get under the skin. All right, so you do a reconstruction. In this case, I would use a muscle and suture it in place, right? Use the suturing all around to keep it in place to cover the raw surfaces. All right. Anyways, and then usually when we have a bigger tumor and we have SCM, you have to use a drain. This is the drain going through the skin, and this is the drain with perforations in it to grab any fluid, right? Now, if your drain was removed, and I'm assuming that's what's going on, that you don't have a drain in there, and saliva is leaking from these surfaces and collecting under the surface, so the skin is bulging out. So this is the skin bulging out, the fat underneath it bulging out, and the fluid, the saliva, let's do the saliva in blue. So the saliva that's coming from this cut edge is accumulating under the skin. Okay? So basically, what you have is only saliva under the skin. So you also wrote that they drained it yesterday. So what we can do is put a needle in here, a small needle in here, take this fluid out, okay? Take it out and then put a pressure wrap around to push on it so there's no space for this to come back. What I would also do is I would also take antihistamines, right, like Benadryl, Allegra, that cause less saliva production. There's scopolamine patch can be used, scopolamine. Your doctor can give you. There's this medicine called Elavil, which was an old antidepressant that people stopped using because it was causing dry mouth, which the side effect is it makes you have less saliva production. All of these can work, and you can do all of them together to decrease your saliva production. A fistula is if there's an opening in the skin and this is coming out. So there's a fistula between the saliva gland and the skin and to the outside. But if you don't have that, connection to the outside, then all you have is a seroma or sialocele, which is just a pocket of saliva. And what I generally do is, because this happens usually within the first 5 days after surgery, I put a needle in, drain it out, and put a pressure wrap around it. I have these Velcro straps that are often used for facelifts, right? Plastic surgeons, but they work perfectly well for this because they put pressure on this area and don't allow collection of fluid. And it's not a very scary thing. I like draining it and putting pressure on there because I feel like that forces these layers, this layer here, that's not stuck to the muscle. Let's do it in green. So this edge here, that's not stuck to the muscle, to come down and adhere to the muscle, right? And once those fibrous bands are formed, there's no more space for the saliva to get into, and hopefully by then this area will have healed well enough that it seals itself, right? And that's what you're aiming towards. Now, majority of times, if you don't even do anything, in time your body absorbs the saliva and that closes, but it just takes much longer, okay? Now, if you don't put a pressure dressing, it will fill right back up every time you get hungry or you eat. But it's not a scary thing, Stacy. You can manage this, and you can manage it well. Make sure you either take an antihistamine, scopolamine, or Elavil, or you can use a combination of all of it to decrease your saliva production, okay? And put pressure dressing, you will be better. All right, very good question. Thank you. All right, Liz and Company. Thank you for your time, Dr. Larian. Much appreciated. My question is, what is the most accurate test to find out what type of tumor you have? Needle biopsy. At this point in time, needle biopsy is really the only thing we have, okay? The future, I think, so this is a needle biopsy where you take a small needle and put it in there. This small needle has a hollow bore, right? The middle of it is hollow. So as it's going through back and forth, it'll get some tumor cells inside of it. And so, here, let's do it here too. Inside the hollow bore of the needle, and then you pull it out. I know everybody's concerned about seeding of tumor as you do this. Unfortunately, there are no reported cases of a tumor seeding around with a needle biopsy, right? With a core biopsy, which is a much larger needle, there is a chance of that. This is comparison of a needle biopsy versus a core biopsy, which is much thicker, okay? Core biopsies are rarely used, but you must have a good reason to use them. In any case, with a needle biopsy, you can get into this tumor. And the good thing about the parotid is that because you're so close to the skin, this being the skin, this is cross section. This is cross section of this area, right? So because you're so close to the skin, the tumor is usually fairly superficial and not deep. Even if the tumor was here, you're only going through skin, fatty tissue under the skin, the parotid itself, so you're not going far to get to it. In any case, you can get very good results. The resulting, the reason to do all this is obviously because there's 15 benign and 21 types of cancers that can happen in the parotid or in the salivary glands. You want to know which one you have, because once you know which one you have, you know how to address it. You know that in the case of these 14, you can sit and wait and not necessarily jump on it and see if it's going to grow, right? In case of a pleomorphic adenoma, this can turn into a cancer, so you have to take action, but you have a little bit of time. In terms of the more aggressive cancers, you got to act quickly. In the terms of the less aggressive cancers, right, you have a little bit of time to kind of plan stuff. In any case, it gives you a lot of information. It'll give you how urgent the matter is, what the extent of surgery needs to be in order to address it appropriately. That way you can find the right surgeon, right doctor, the right situation for yourself. So it's a great idea to do, but it's really the only way to do it. Is there a possibility that in the future we can do a blood test to figure out what these are? I'm certain that it will be, right? We're a little bit farther away from that, but I'm certain we'll get there, okay? So M. Burkhardt is asking, do you need to be concerned about abnormal parotid-specific protein in blood work? Yes, not in terms of tumors, but in terms that's something that shows up when you have Sjogren syndrome, which is an autoimmune attack by your immune system onto your salivary glands, and then you get released. So this is the parotid-specific protein is an early marker for Sjogren syndrome or autoimmune disease of the salivary gland. So it's concerning, but obviously not cancer concerning. Okay. All right. Next question is Chararat79. Had a parotidectomy done with temporal parotid flap last September for cynic cell carcinoma. It was stage 1. So happy to hear it. So low grade small tumor without spread. All lymph nodes were taken out and are negative. Well, 17 lymph nodes were taken out in the neck. We usually have 150 lymph nodes on the inside, but that's pretty representative. None of them had any tumor in it and no invasion of the nerve. Great. However, when they did the biopsy for the margins, were close. They gave me the decision whether or not to do the radiation. I opted for no radiation and monitoring instead. Images every 6 months and every 3 months doctor visit. Was under this decision was right. And do you have any situation like this before? Many. I have many patients with a cynic cell, and the problem with the parotid gland is the proximity to the nerve, right? So here, let's say you have a tumor that's this big. Okay, so the tumor that's this big. Let me go to another image because that's we can get a needle biopsy. Here, all right. So even a small tumor like this, even a small tumor like that, here, can be very close to the nerve. This is the nerve, right? So there's very little distance. So even if you do the greatest job on this very small tumor, and once you take it out, you have, sorry, the amount of tissue that you have between the tumor and the nerve is very little, right? And so when you take it out, in this area, it'll be very little. In this area, you could have taken, if you knew this was a cancer from the beginning, you could have taken a lot more, and in this area, a lot more. But right here, the distance is small, right? And so a great number of actinic cell carcinomas that come out will have close margins. And then you have to consider if you want to do surgery or not. And that's a tough decision. It's a very personal decision, based on how fast this grew, if there's lymph nodes involved, which yours didn't show, if there was no perineural invasion in yours, that's a good sign. How much away the margin is, if it's 1 millimeter or half a millimeter or 3 millimeters, that matters, right? The larger the distance, the more confident you can be to not do radiation, okay? If there's any findings under the microscope that define this as a higher aggressiveness, the mitotic figures, maybe even the genetic testing on it, all of those things can play into the decision. But I have to say a great number of my patients with actinic cell carcinoma who have close margins have chosen not to proceed with radiation and have done well. I'm not promoting it. I'm just saying it is an option that you can consider based on how risk averse you are and how risk aware you are, right? So if you're aware of the risk that this can come back and you're going to your doctor regularly and you're going to make sure you see them every 3 months, you do ultrasound every 6 months, at the beginning, on the first day of the month, I tell my patients, the first day of the month, put some soap on your skin and in the shower, feel this area just once a month, not more than that, because if there's a change, you'll notice it on a monthly check. And if you notice a change, like an area here just got firmer, right? You come and see your doctor quicker. So if you have all those things going for you, I think this is not a bad decision, right? Now, there is a chance that genetically yours may be more aggressive and it may come back quicker and it may have spread to the lymph nodes. Those are possibilities, but that's a risk that you need to understand. The percentage chances of all of that is very low, but those are possibilities that can be present and can affect you, right? But if you understand that and you're okay with that risk, then I think it may not be a bad decision as long as you continuously and very religiously follow up with your doctors and do checkups. Okay, very good question. Let me go to some of the questions that have just come in. So M. Hagen 28. Sudden jaw locks while eating, and it's more painful on the side where the pleomorphic adenoma is located, and the twitching and uncomfy feelings every now and then, despite being benign. Should I worry? If you're having twitching, that means the tumor is pushing on one of the branches of the facial nerve, right? So the tumor has gotten big enough where the nerve is being pushed, so it gets overstimulated every once in a while, right? So I think I would take that as a sign that I need to take action. Lockjaw, and the tumor has to be very big in order to push on your jawbone, right? This is the jawbone. And there's all sorts of tendons keeping it in place, right? And muscles. These are muscles around it. So those muscles are keeping it in place. So for a tumor to be able to push this out, it has to be really big and firm so it can create that much of a push, okay? So I don't think the lockjaw is related, but the twitching is concerning. And you know, one of the signs that a tumor has gone transformed into a cancer is constant pain. So if you're having constant pain, then I would look into it a little bit deeper. All right. I'm looking at more questions. Let's see. And Mahajin28 says, also my doctor here said that there will always be a chance of temporary paralysis for my case, deep lobe PA. Is that true? All right, let me show you the anatomy of the deep lobe. All right. So the parotid gland has been artificially compartmentalized into the superficial lobe and the deep lobe. And it's artificial because what we say is that anything superficial to this facial nerve, all of this we designate as superficial lobe, and anything deep to it, we call it a deep lobe, right? And those designations are pretty clear where you have nerves. But in the areas where you don't have a nerve separating this from that, in between these in-between sections, right? This designation is very artificial. Okay, now, you can certainly have superficial and deep lobes, and you know, tumors can be up here, superficial, or down here, deep lobe. And the tumor in the deep lobe, it depends on its growth rate. So if it's growing more inwards towards the throat, it's less likely to push on a nerve. If it grows this way, it can push and move the nerve around, right? It really has to do with two factors. The chance of getting temporary weakness has to do with experience of your surgeon, more than anything else, how meticulous they are, how slow and patient they are in treating this, versus, and also how big your tumor is and how much contact it has with the nerve, right? But having said that, it's very common that tumors have intimate contact. So let's say in this scenario where the tumor is pushing the nerve upwards, right? In this scenario, the first step is to make an incision in the parotid and separate the parotid. Find the facial nerve branches, all right, facial nerve here, and the branches that are close to this particular tumor, and you can see the tumor just underneath it. And then move the nerve over to get underneath and take out this. And sometimes you don't even need to move the nerve over, right? If there's a little bit of space here, if there was a little bit of space between the nerve and the tumor, then I wouldn't even need to move the nerve over. I would just go underneath the nerve and remove the tumor, okay? But depending, again, that's where the experience of your surgeon comes in, and then take that out. The good thing about deep lobe tumors is that the reconstruction is much simpler. Put it together, you don't need a muscle flap, you don't need a drain, and it's done, all right? So let me show you one example. This is a picture from surgery. This is the microparotidectomy for a deep lobe tumor. You can see the tumor here. This whole thing is the tumor. And you can see the facial nerve coming, going over it, giving a branch that goes up and a branch that goes down. So the tumor is actually stretching the nerve upward, right? And this is after the tumor is removed. You can still see the nerve and the two branches of the nerve, right? Completely being preserved. And this patient had no weakness of their face. So there is a chance that the person get weakness, someone who has this kind of a configuration, but there's also a chance that everything will go well and nothing untowards will come. This is another deep lobe tumor. You can see, again, the facial nerve coming and having multiple branches, and then the tumor itself, which is mostly in between the branches but bulging out, and this is after the tumor was removed. So the tumor was removed here, and you can see all these branches, and you see that the branches look, let's see, let me erase this. The branches look pretty healthy here and pretty healthy there. They're not bruised or swollen, and this patient had no weakness at all. And this was also through a microparotidectomy approach. You can see the earlobe being flipped upwards, right? So normally the ear would be like this, okay? And now it's getting flipped up by this yellow hook, which has a hook in it, just like this hook here. And these hooks help me visualize better, right? In any case, small micro incision. And this is the surgery. These are the probes that monitor the facial nerve. And this is the surgery for our deep lobe. And the tumor is coming out right there. And now doing a reconstruction, putting it together, sewing the skin together. And a 3-hour surgery shown in 30 seconds with time lapse. Anyways. So it's possible that it can get injured, but fortunately not likely. All right. Nancy Carew. Nancy Carew, you're asking questions not about salivary glands, but rather about parathyroid glands. So let me see. 52-year-old with calcium 10.7, PTH of 66, ALK-Phos of 138, vitamin D 15, now 25 after taking vitamin D. 24-hour on calcium 550, ultrasound scan negative, still haven't gotten. Nancy, you're on the right track. You certainly and definitely have hyperparathyroidism, and the 4D parathyroid CT scan is the next step to try to help you out. In any case, we are done with the questions for salivary gland diseases. Let me check here on Facebook and see if any other questions have come up. No, we are done. Very good. It's been a pleasure. Thank you for your good questions. Hopefully you'll find this helpful. I'll post this video so people have access to it later on and can see. If more questions come up as you see this video, please contact us, send us a message, and I'm happy to answer it for you. Or if you have more detailed questions, and you can set up a video consult, a Zoom consult, and I can look at your images remotely, look at your pathology reports, everything you have, and give you my 2 cents.